Well, good afternoon, everybody. Encourage you to grab your lunch and sit down. We have a very full agenda today. Great to have you all here. Thank you for joining us, and I will try to speak louder, both for the benefit of the folks that are here with us in Sacramento, as well as the significant number of folks we have joining us today on the web, as well as on the phone. We will get to this a little bit later, but when we open the floor for audience Q&A and as we have discussions, please make sure you're speaking into a microphone, which Crystal will bring to you so that everyone that's with us today is able to hear your questions. Today's event is called the ABCs of APCDs, How Data Can Improve Healthcare in California. And my name is Christoph Stremikis. I direct the Market Analysis and Insight Program at the California Healthcare Foundation. CHCF is an independent, nonprofit foundation dedicated to improving the healthcare delivery system in California, particularly those with low incomes and those who are not well served by the status quo. We are thrilled, I am personally very excited to welcome a panel of state and national experts who are with us here today to talk about the use of all payer claims data and the terrific opportunity we have here in California with the passage of last year's budget. But before we do that, let me just take a moment to acknowledge the many people who are working behind the scenes to bring you today's event. A big thank you. This is always dangerous to name names, but thank you Crystal Haswell, Karen Shore, Katie Rodriguez, Sally Mudd, April Reinhart, and the many other staff members who make sure events like this happen so smoothly. I also need to particularly single out and embarrass Danny Sandoval today. Those of you who know Danny know he's here, he's working hard, he's got a smile on his face. He's covering his face because today happens to be his birthday. Happy birthday, Danny, and thank you to everyone for all your work pulling this event off. One more brief logistical thing to mention. As many of you know, CHCF periodically holds these events as a way to bring together the Sacramento policy community on important topics. Our next briefing will focus on the drug Medi-Cal organized delivery system. That's scheduled for December 6th. I believe that's in this room, but please check our website, chcf.org. All of the information that you need about that briefing is on the site. The agenda for today's event is in your packet. You'll see it's quite full, and we do want to save time for your questions at the end of our panels, so let's begin. Increasing the availability and utility of health data has long been a priority of both the California Healthcare Foundation and many other stakeholders throughout the state. Access to aggregated information, including the claims and encounter data that we're going to talk about today, is crucial to understanding and addressing the performance of the healthcare system. It's been used to inform and address many topics of particular interest here in Sacramento as well as throughout the state, including healthcare cost drivers, utilization patterns, and public health outcomes. Since 2013, the Foundation has supported the collection and dissemination of claims information through a multi-payer claims database run through the Integrated Healthcare Association. That effort is called the California Regional Cost and Quality Atlas, and if you haven't visited the Atlas recently, I would encourage you to do so. A link to the Atlas is available on the event page of the CHCF website. But there are also many other APCDs that we can point to throughout the country. Currently, 24 states are implementing or already have functioning APCDs, and we're very excited, as I said, to have several here with us today to discuss how those data sets are being used by various stakeholders. We also have experts from the National Association of Health Data Organizations, or NADO, and the University of New Hampshire here to discuss an implementation framework that other states have found useful as they implement their databases, and they will also provide us with some important design considerations as California potentially begins a new statewide effort here. But before we get to other states, let's think about ourselves for a minute. Let's talk about California and what's going on here. I would invite Scott Chrisman from the Office of Statewide Health Planning and Development, or OSHPD, to the stage. We've asked Scott to provide a brief overview of the opportunity provided under AB 1810, this year's budget bill, as well as how a statewide claims database could complement the excellent data products and information that his office publishes. Scott?
Appreciate it. Thank you, Christopher. Appreciate it. And thanks to the California Healthcare Foundation. We would appreciate the chance to join a convening like this and actually look forward to learning from what other states have done. So as Christoph indicated, I really wanted to introduce kind of the direction set forth by the legislature in Assembly Bill 1810. Again, it wasn't a standalone bill. This was part of the budget. So 1810 actually has a whole bunch of content, and we're responsible for a couple of pages. So I'll focus just on that as we go forward. There's been a number of bills in the past you're certainly aware of, and actually we had called it very different things. In this case, the legislature landed on healthcare cost transparency database. Of course, we're really talking about APCDs broadly, although that's not the name we put on it. For us at OSHPD, who manage other data programs and actually a couple other cost transparency data initiatives, we're just going to refer to it as healthcare payments data program for planning purposes. So if you're not familiar with OSHPD, just briefly, we really work towards safe and quality healthcare environments, and we do basically four things. We ensure safe facilities, and what this really revolves around is our responsibility as the building department for hospitals. So in terms of building code, plan review, permitting construction, and really a focus on seismic safety, which of course is a tremendous concern here in California. This is really a substantial part of our mission, and actually we have teams deployed in the field right now inspecting facilities around the Butte fire. So very important responsibility, and again focusing on safety of the healthcare infrastructure. Financing emerging needs, we manage an assurance program. We actually provide loan insurance for healthcare construction, so to provide opportunities for additional access to care across California. In terms of workforce, we actually provide a whole line of programs, scholarship and loan repayment, really focused on expanding access to care through those kinds of investments, and a focus on underserved communities. So the idea that we'll provide loan repayment or scholarship, and in return physicians and PAs and NPs and nurses and other healthcare professionals agree to serve in these areas. So again, expanding access to care. And then finally, in an area that we're really focused on in my division is supporting informed decisions. And we do this through a number of healthcare data programs. Certainly we collect a lot on utilization, both at the healthcare facility level and also at the patient level. So for a couple of decades we've collected inpatient discharge data, as well as emergency department encounters and ambulatory surgery that originates in hospitals, not so much in freestanding facilities. From that, we actually have a number of healthcare quality reporting programs. We do a number of risk-adjusted outcome studies. Probably the most significant is around heart bypass, or the CABG program. But we also have a number of other mandated reports that we prepare, and then other sort of custom opportunities. We're working on mortality indicators, and I think we're starting up patient safety indicators next year. So, and always looking for opportunities that are of value to our stakeholders across the industry. Cost transparency has been, interestingly enough, something that we've done around hospitals. We've collected detailed financial data from hospitals for over 40 years, actually, and I think it's an incredible source of information that is certainly significant transparency. I don't know that we've ever branded as such, but it's been a very important program for us and widely used data, in addition to a number of, I guess, smaller collections that the legislature has assigned to us: community benefit plans, charge masters, as well as fair healthcare pricing or discount policies. This all originates from hospitals, but again, I think it points to work that we'd had as part of our mission around cost transparency, which certainly has been a theme that's emerged as of late that really we're talking about here today. And then a couple of other areas in terms of healthcare workforce. In addition to the programs, we actually have a data program around healthcare workforce referred to as the clearinghouse. Again, this was another statutory program that we developed probably 10 years ago. Focuses on aggregation of licensing data as well as some education data to look at pipeline and other trends in workforce. We continue to develop that. And then finally, as I'd mentioned, our role around hospital safety, building safety. There's a substantial amount of data around building safety and hospital construction, including seismic readiness. That's been a significant lift here in California as of late. So in terms of the theme I'd mentioned, just in the last 18, 24 months, it's been a significant focus of the legislature. Many of you are familiar with SB 17, which is around prescription drug cost transparency. And again, this was something that was, again, assigned to us in statute. It was a new area in that, as you can see, most of our work around data collection has been done from hospitals and other healthcare facilities. So we kind of set out to expand in this regard, work around cost transparency and with a new stakeholder group, which includes prescription drug manufacturers and purchasers of those prescription drugs. So the piece I would highlight here is, we've been working on this for the last year, finishing the rulemaking process. We expect those regulations to be in place by January 1, and we'll begin the new data collection in the first quarter of next year. I want to really emphasize how we sort of manage the stakeholder engagement. Again, it's a new process. We conducted a number of workshops and sort of had a number of conversations and ongoing dialogue with the new stakeholder groups, both users of prescription drug data, the purchasers represented, again, in the statute. That was very important, and it was equally important to spend time with drug manufacturers. Again, this is a new process in terms of collecting prescription drug data. So that was very important, and I think we'll bring those same sorts of lessons to this planning effort for an APCD or healthcare payments data program. Let's see. Okay, so that brings us to today, or the budget bill. Again, it wasn't a standalone policy bill. It was a piece of the budget bill passed in June. That really outlined a couple of key provisions, assigned the responsibility to OSHPD to, number one, convene a review committee of stakeholders, and the stakeholder groups are outlined in the statute if you've seen it, and has some specific details there, and that sort of is in progress. We're working on that and looking to work with the new administration to begin that process, and then develop a legislative report by July of 2020. So that's sort of the key place to start. That ledge report needs to really have a kind of a soup to nuts plan on how we would stand up this healthcare data payments program at OSHPD and sort of satisfy and speak to the intent of the legislature as proposed in the statute. I wanted to note kind of the work that's come before, and Christoph had mentioned that this is unlike, I think, SB 17, which was kind of new, and California, if not one of the first out of the gates. This is obviously work that's been done by many other states, and I'm looking forward to hearing from our colleagues from other states today. And so there's been a lot of thinking, and there's been a lot of thinking in California. I think a lot of policy work's been done. A number of bills have cycled through. So that's good. There's a lot for us to build upon as we engage in this sort of planning effort to build that report. And I wanted to highlight work that was done by the California Health and Human Services Agency, and Katie Hydorn is in the room. Had the pleasure of working with her on this report, which was essentially complete and presented in early 17, so almost 2 years ago, based on another statutory requirement. So some of the key findings I wanted to highlight for you. Number one, as mentioned, look at what other states are doing. A lot of work's been done. I think we're at we'll learn more, 22 states perhaps and counting. So there's a lot of lessons learned, a lot of material for us to glean in terms of what works and what perhaps doesn't work, what things we should avoid in terms of pitfalls and where we should focus on for success around this kind of effort. look at existing efforts, existing systems in terms of what's happening in the landscape. And we did look at Integrated Healthcare Association. Christoph had mentioned the excellent work being done on the cost and quality atlas there. We looked at CHIPI, Cal Index, which is now Manifest MedX, another player in the space, and we also looked at San Diego Health Connect. Of course, they're more in the health information exchange space, so that needs to be kind of weighed in terms of transactions around clinical data for patient care and healthcare payments data. Really, I think the intent of the legislation is much more around policy and driving informed decisions in that regard. But these were some of the other findings. Focus on use cases. I think we'll hear that from our colleagues as well. The idea is not to get a bunch of data. The idea is to focus on some key areas where you can address important policy issues around cost and quality and other issues that might be addressed with those data. So we'll I think, take that lesson as key. Leveraging existing systems. This is really important, not just because it was a finding of this analysis that sort of precedes the work before us, but it's also something that Health and Human Services Agency has focused on in recent years as a broad principle around IT investments and data initiatives. The idea that there are resources that exist today that should be leveraged, and then certainly understanding the gaps that are required to be filled in. So looking at what's existing, being able to leverage existing investments was an important finding in terms of how this might be approached. Again, more on use cases, looking at funding models. I think we'll hear more from other states about how this is funded. There's a couple of different models, submitter fees, matching funds from the federal government, consumer fees, et cetera. And then again, in terms of access to data, how it's made available or not made available to third parties. California obviously has unique challenges because of the amount of capitation and managed care and sort of the complexity of those relationships. That's something that's obviously going to be front and center in terms of how we would approach this kind of work. And then some IT considerations, looking at cloud computing in terms of more cost-effective or cost-efficient approaches to the infrastructure, and then trying to manage the ETL, or the transformation of those data as much as possible, because that becomes incredibly costly, of course, given some of the the uniqueness of the data. Mapping becomes a critical key, so it's trying to balance that. So we take those findings from the work prior into this current effort, which again really focuses on a complete legislative report on how we would do this. There was an appropriation, one-time appropriation to help initiate this effort. Our focus really is on preparing the ledge report and a kind of thorough planning to present that to the legislature and to get hopefully approval to go forward at that time. In terms of the report, you see it reflects a lot of what were the findings and the analysis, and I think the idea would be to go deep dive into these over the next year and working with the review committee, pull recommendations, and then build those into the ledge report. But again, focus a lot on use cases, purpose of use. This is all right out of the statute. What are the data to satisfy those use cases? Who are the data coming from? Privacy and security always is paramount, especially in California, right? Constitutional right to privacy. So it's going to be a critical issue in terms of how these data are managed. Existing and available technology goes back to the principle of leverage. What's available today? What needs to be built or sourced, if you will. Certainly additional legislation. I think what's in 1810 in itself would not mandate reporting. We really need to go back and say this is what's required for not just sort of compliance or mandatory reporting, but certainly financing, long-term sustainability, which is cited in there without any general fund, right? No tax revenue would be going to this. So we need to come back with part of that as a plan, governance, and then of course requirements for data linkage. I'll say a couple things on data linkage and mapping to other data sets. Again, based on work that's been going on for several years now in Health and Human Services Agency, and really to the credit of Secretary Wilkening and Secretary Dooley before, we've really done a lot of work to support data sharing within HHS departments. So why it's important here is that a framework's in place where we as a department of HHS can work with our partners, and we are doing this today with the Public Health Department, with healthcare services, and other trading partners to actually share data sets and link those to the data that we manage today, inpatient data, emergency department encounters, and others. So that's actively happening now regardless of kind of the direction of this work in 1810. So we're excited about that. And again, I think the Health and Human Services Agency has done a lot to sort of set the foundation for us to be able to bring some of these assets together to get a fuller picture of healthcare in California. Obviously, the addition of payments would be very important. I think this is my last slide. I wanted to leave you with sort of our goals, what we'd like to do, or where we've been heading as a department, is really to kind of expand some of our quality reporting that's been a important piece of our mission and our work in the last few decades, and bring together some of these data sets, including other CHHS data that we are working on today with partners, and certainly healthcare payments. I think this is an opportunity to present a case as to why that's an important part of the equation. I think we're going to learn more about that from our colleagues, but really for us to be able to provide a more kind of full, complete cost and quality reporting out of OSHPD to really inform those important decisions and policy making around California. So that's what I have for you, and I appreciate the time this morning, Christoph. Thank you.
Thank you very much, Scott. I think there are two things that we really have going for us here in California. The first is the tremendous track record, ability, and talent that Scott and his team bring to an effort like this. And the second thing, which Scott mentioned, is the expertise and the experience that we have across the country and in other states. So at this time, I'd like to invite our national experts and our state folks up to the stage here. We'll have them sit here, and I've been told to ask you to please use the stairs over there so you don't...
Thank you.
As they're coming to the stage, you'll see in your agenda, we'll ask the folks from the states to spend about 10 minutes each talking specifically about some of the use cases, some of the ways in which their data sets, their data has been used to inform important policy discussions and inform stakeholders in their quality improvement and other activities. After we have the states work through their use cases, we'll then turn to Denise and Joe to talk about an implementation framework and some of the important considerations that they've learned as these databases have been stood up in other parts of the country. Why don't we go ahead, I'll just do a quick introduction, and then we can go ahead and get started. From all the way on the left there, my left, your right, is Craig Wilson. I'll let Craig introduce himself, but Craig is joining us from the Arkansas Center for Health Improvement. Next to Craig, we have Deb Scheel from Massachusetts and the Health Information Agency there in Massachusetts. We've then thrown you a curveball and put Joe Porter in the middle. Joe is from the University of New Hampshire and co-chairs the All-Payer Claims Database Council. And then Anna English from the Colorado APCD. And then finally, Denise Love. So with that, Craig, do you want to get us started and spend about 10 minutes talking about the All-Payer Claims Database in Arkansas and how various stakeholders are using it? And please use the mic.
Sure.
Thanks.
I'm the Health Policy Director at the Arkansas Center for Health Improvement. We are a policy shop. We have a policy team, we have a research team, and we have a data team. We've been involved in collecting data from various state agencies, including claims, for probably about 15 years. So we have a significant amount of experience in collecting and looking at claims information, primarily for policy purposes. So that's what we've been doing on a permissive basis for a long time. Just to give you, I think it's important to give a little bit of context on the Arkansas Healthcare Transparency Initiative, which the engine of that is the all-payer claims database. It's what drives the initiative, and I think that's an important framework that is shared here in California. It's the overarching initiative of healthcare transparency, within which you can bring not just an all-payer claims database, but survey information and consumer experience information and other databases, which we are actively exploring and have been successful at over the last couple of years. But I'm probably, Arkansas is probably the newest resident on the block of all payer claims databases. So I do want to give you a little bit of context, and it comes in the context of my toddler. I have an almost 2-year-old, and that's kind of where we're going to lead to. But just to give you a little bit of an analogy that I hope level sets for California in terms of where we have come from and where we are now. And that is that we spent a couple of years just in the courting phase. We were talking with the insurance department, we were talking with other states about what these all-payer claims databases were and how they could be used, much in the same position where you are now. And then our Arkansas Insurance Department, luckily, they put a ring on it, and they applied for some funding through the Center for Consumer Information and Insurance Oversight at the federal level to provide the state with some funding to build the infrastructure for an all-payer claims database. And then in 2015, we walked down the aisle of the General Assembly and we got married into a mandate that required the private sector and our Medicaid agency to submit claims information to the all-payer claims database. We went through about a year of thinking about having a baby, and then in 2016, we were prepared to then collect data. And even with our experience in having collected data prior to that, it took a while to educate the entities that were going to submit. So I think that's important. And we birthed that baby, and now it's kind of in toddler. It's kind of trying to walk right now. So that's kind of where we are. We have collected information as far back as 2013. We, as a policy shop, are also, we're not only the collectors, we serve as the administrator on behalf of a state agency, but we're also a user of the information from a policy standpoint. So we now know on the back end kind of, all right, how can you use this data? Where are the gaps? What are the issues with it? So I think that's an important point. We kind of serve a little bit of two roles. In our about 18 months that we've had the APCD opened up to external users, we've had about 40 requests. Maybe what you'll hear from other states is that about half of those come from state agencies. I don't think they realize that that they would use the data to the extent that they have, but you build it and they're going to come. It's there, and they see value in it once they begin to use it. So some specific use cases. I know there's a lot of interest in opioids nationally, and certainly in Arkansas, where we have 1.14 opioids prescribed for every person in Arkansas. So we're second in the nation on that, so it's a significant issue in Arkansas. So we've been able to look at a Medicaid policy in 2016 to compare, to look at prescribing for new users of opioids. And they put a cap on the days, 7 days for a new user for opioid prescriptions and 50 morphine equivalents. And so we were able to look at that compared to the private sector, the commercial plans, which do not have that. And what we found was the Medicaid policy was in fact working. They saw fewer prescriptions and at lower doses. So that was important. From a provider standpoint, we have been able to assess the number, and you got to think about your stakeholders when you're kind of putting out information for value proposition. So we wanted to think about the providers as well. Assess the number of days until a claim was paid from the time it was submitted. Because providers and their revenue cycle management, they depend on those payments coming in. And let me tell you, some payers pay quicker than others. There were some differences, about 75 days from submission to time of payment compared to some others, which were in the 20-day range. So that can both inform contract negotiations, and it can also inform policy at the state level if you want to do a maximum number of days from time of submission. And on the cost front, that's kind of probably where we've been most active. We've looked at utilization and pricing of air ambulance services to look at balanced billing practices, looking at average charges of around $35,000 compared to the average allowed amounts of around $5,000 to $10,000, which exposes individuals to around $25,000 to $30,000 in balanced billing from the provider for air ambulance services. And that's been very key, and that document actually made its way into the congressional conversation recently, where the Senate has developed a bill around balanced billing. Senator Bozeman from Arkansas used that document in his conversations there. We've looked at provider payment differentials between Medicaid and qualified health plans on our health insurance marketplace as part of a waiver evaluation. And what we saw was that Medicaid, was that private payers were paying about 100% more across all services than Medicaid was paying. So that can inform some reimbursement policies in Medicaid and explain some access issues. We've applied Milliman's health waste calculator to look at the cost of low-value services as defined by the Choosing Wisely campaign in our public school and state employee health plan, and we plan to look at that across Medicaid and the private sector as well. When EpiPen was a big issue and the costs around that were an issue, we got a state-specific look at the costs of EpiPen that had grown by $200 from $250 per prescription to $450 per prescription in just 2 years. So we were able to really look at a state-specific analysis on that. Most recently, our legislature has been focused on tax reform, and so they're looking at ways to both cut income taxes and raise revenues in other places at the same time. And so we were able to take and update an estimate on tobacco-related or smoking attributable costs that was out of date and didn't rely on claims information. The previous estimate was around $293 million for our Medicaid program. When we looked at actual claims information and updated that estimate, it was more around $795 million, which far exceeded the revenue generated by our tobacco tax. Just a couple of things moving ahead that in the policy space are going to be particularly critical for us. We've linked medical marijuana qualifying patient information. Yes, we do have that in Arkansas. And so we'll be able to take a pre-post look at the implementation and utilization and costs in healthcare claims pre-post implementation of medical marijuana in Arkansas at the individual level. Because we've linked it with the claims information. We're taking in jail data from the county jails to look at the implementation of crisis stabilization units to see whether or not there's reduced recidivism on the jail side and reduced costs on the health care side, particularly for our Medicaid program. And then most recently, our Office of Medicaid Inspector General has come to us to look at differentials in payment for flu immunizations, which what we found last year when we had a big flu outbreak like we did across the nation, that our Medicaid, our providers were not providing flu immunizations for Medicaid patients because the rate was so low that it exceeded their acquisition costs. And so right now we're looking at those differentials to make reimbursement changes to increase that reimbursement rate to more closely match what we see in the private sector. So those are some of our use cases. I've got copies of all those, and I'm happy to provide those.
Thank you so much, Craig.
A little bit so my feet touch the ground. A little awkward. I'm Deb Scheel. I'm from the Massachusetts Center of Health Information and Analysis, otherwise known as CHIA, like the pet. And we were formed because Massachusetts had healthcare reform before everyone else. So in 2012, they wanted to track what was happening in terms of healthcare costs, utilization, and quality. So they passed Chapter 224, which created CHIA. And our role is to make sure that we make healthcare costs transparent so that and monitor the system. But we don't make policy. We don't do policy. They did form our sister agency, the Healthcare Policy Commission, and they're the folks that we work very closely with. So we feed them data, we feed them reports, and they make policy recommendations based off of the data. And 2000, we were formed actually from the Division of Healthcare Finance and Policy, which has been around for 30 years, and they started the all-payer claims database a little bit earlier than CHIA. So we're now on our 7th annual release of the APCD. We just came out, I think, this month, so I have a bunch of use cases to go over, but basically the Health Policy Commission produces an annual cost trends report, and they use the APCD in addition to other supplemental data sources. The APCD we were just talking earlier doesn't give you all the answers, so a lot of times you have to add supplemental data reporting. So they produce their report every year, and they highlight trends in cost, utilization. This year they improved with linking the APCD with registered provider organizations, so all the large group practices have to register to Health Policy Commission, and so that way you know how hard it is to track which providers are linked with which provider groups. Every year they have to register, and we update that data. So they are actually to be able to trend cost and utilization for provider groups for the first time this year. So it's a tricky thing to do. It's done once a year, so it's a snapshot in time, but it's been effective to kind of track what's happening with provider groups. It's always a challenge. Another way, CHIA, in addition to transparency, making sure that data is transparent, we started our consumer cost transparency website in the spring of this year. And so consumers can go onto our website and be able to look up cost by procedure, and then they get provider cost, which is actually the allowed amount. So it's not actually charges, it's actually the average cost. They can look it up by zip code, they can look it up by payer, and they also have quality metrics for the hospitals on there. So if they're looking at a hospital-based provider, they can see what their leapfrog measures were, for instance. They also have some consumer guides that are procedure focused to help them navigate the healthcare system, so we find that that's useful. So that's kind of on a beta site, and we'll be adding things like pharmacy costs to that in the future using the APCD. One of the things we also did with that website is we know that everyone, like payers and providers, want to know how they are paid compared to everyone else. Policy makers want to be able to use that data. So going through a consumer website is kind of clunky. So they can request the underlying data in an Excel spreadsheet. So those policy wonks can go through and be able to compare costs in a more user-friendly fashion. We also, for the first time this year, too, produced a pharmacy cost and use report, and we were able to show the breakdown of therapeutic classes using the APCD, and then what their average cost, what their number of scripts per person, and then we took the 10 by the allowed amount, most expensive therapeutic classes, and we broke out for each therapeutic classes the individual drugs for the top 5 and what their average costs were, also whether they were generic versus brand name. And we'll be producing that report again, but trending it this year for the first time. Another big issue in Massachusetts is the opioid epidemic, as it is, I think, everywhere. And the Chapter 55 was passed in 2015, signed by Governor Baker, to be able to monitor and actually gave us the authority to link the APCD with all sorts of public health data and other data from jails, and be able to create files and reports so that we can inform policy on kind of attacking the opioid use disorder epidemic in Massachusetts. So they produced reports, 2 reports. The APCD was the spine of the report. They linked ambulance data, they linked toxicology data, death data, birth data. They linked, let's see, the jail data, actually, I think state police data, to be able to track and get a really good look at what the prevalence of opioid use disorders are in Massachusetts, and then also be able to understand the prescribing history, both within and outside the within jails, within mandated, what their behavioral health background was, what their prescription history is for these folks. And then that way they can inform policy. Some of the interesting findings were that women tended to have 3 or more providers and pharmacies prescribing their opioids more than men, and just that folks coming out of jail have a 56 times more likelihood of dying of opioid overdoses. So it was I think it can help target and focus the needed resources to be able to affect with the opioid use disorder issue. The other thing Massachusetts did to try to offload, since the payers have to jump through hoops in some respect to give us monthly, we receive monthly data files from the payers. We also want to try to reduce their burden on state reporting. So, and we call that our admin simplification strategy. So whenever possible, we try to run reports off the APCD and leverage those reports so that they don't have to, for instance, report quarterly enrollment reports to our Division of Healthcare and Insurance. And we kind of develop the reports, get their approval, and then for a little while we run it simultaneously, then we turn it off, and then they can actually they don't have to do it themselves. We produce those reports for them. I think that's about it that I have. I think.
Deb, thank you. That
welcome.
was very helpful. Anna?
Hey, my name is Anna English, and this is on. I'm with the Center for Improving Value in Healthcare, otherwise known as CIVIC, CIVHC, spelled that way. So CIVIC came about through the recommendation of the Colorado's Blue Ribbon Commission on Healthcare Reform back in 2008. And the APCD was established through legislation in 2010, and really that was the birth of CIVIC as well. CIVIC was named then as the administrator by the Colorado Healthcare Policy and Financing Department, which also is the same group that manages the Medicaid program. We are independent. We are outside of the government. We are a nonprofit, and we are nonpartisan, which sometimes is very hard. We're also agnostic as to the role and the services that we provide to the various stakeholders. And so we like to call ourselves Switzerland, and at times it's very, very difficult to manage to, but we work very hard at it. You know, our goals are really simple, is to achieve the triple aim, lower cost, better health, and better care delivery or better quality. And then the other thing that we are mandated by statute is that everything that we do through the APCD has to benefit Coloradans. And we get a lot of requests from national researchers, and it's very easy to have publications that benefit Coloradans when they're using only Colorado data for that. So our areas of focus are first and foremost data transparency, and we'll talk a little bit more about that, or I will, payment reform, and then obviously delivery system redesign. The Colorado APCD is really considered to be the most comprehensive database within obviously the state of California, or excuse me, Colorado, not California, but also very, very population dense as it relates to other databases within the nation as well. We have medical, dental, and pharmacy claims. Colorado Definitely not the state of California. We have approximately 4 million lives that are represented within the database, but that does account for approximately 80% of the population. We do have monthly submissions. We get commercial, Medicaid, and Medicare fee-for-service, as well as Medicare Advantage coming into the database. We are a qualified entity, which Civic is obtained on its own. And then we also operate as the state agency for Colorado in receiving Colorado medical claims, so we can use the Medicare data for research as well. Our mission, very simply here, is to empower individuals, communities, and organizations through collaborative support services and healthcare information. You know, in essence, what we try to do is inform. And we've evolved to really work towards presenting the data that allows for strategies, priorities, and tactics. And what we're trying to move from is the continuation of more talk into action. And I think that's the challenge for every single one of us. And when we're bringing in this unbelievable asset, which is the state's all-payer claims database, is how do you make this information as useful as possible? Because if you keep limiting how you can use the information, then you're limiting the value. And so that's really been the challenge from a Civic perspective. So really we talk about, okay, from delivery system. Civic also is the managing partner for what's called Healthy Transitions Colorado. And we basically bring together a large number of organizations to really look at how do we improve the communication and the flow of services amongst the various facilities. We also convene a statewide palliative care group. And again, in each case, we use underlying data within the Colorado APCD in order to determine ROI. What are those right types of services or those types of services that can perform a return on investment, whether it's quality-based or whether it's cost-based. And again, a lot of discussion is occurring in Colorado as it relates to cost. Payment reform. Right now, if you look at, and I will talk a little bit about the public reporting, but if you go to civic.org and you go to the button that says Get Data, and you'll see public, there was a new report that was just issued, and this is the second annual report that Colorado participated in on total cost of care. It looks at resource use and it looks at prices. Colorado was ranked the lowest as in not the better one, but the worst one as far as our overall cost. And again, we had very specific areas of utilization that we were high, which was pharmacy, and a lot of studies being done specifically on opioid use, but pharmacy use in general is extremely high within the state of Colorado. And the other one is outpatient services. But as it relates to price, in all four categories of price, Colorado was high. You know, so it has, last year we were at 17% based on the 5-state average. We were 17% higher than the average. Now they were 6 states and we were 19% higher. And again, based upon a number of different items. So on payment reform, we have been looking at a number of different items as we've been looking at episode-based services, doing comparative analytics, looking at the various regions within the states, but also taking into account how do we compare and benchmark ourselves against other states as well. And in the other area that we're looking at is specifically on reference-based pricing, which we also we use the term of contracting. Again, it's a basis as to how do we compare ourselves to other benchmarks such as Medicare. In Colorado, the range of prices at specific procedures go from 250% to over 1,150% of Medicare. A lot of opportunities to make some significant changes and make some improvements in our overall cost structure within Colorado. And what's happening is there's some very specific pilots. Grand Junction is an area, there's actually meetings going on tomorrow regarding how do we make those changes. And also I welcome all of you to go to, again, civic.org and take a look at, we have an interactive reports that are online that look at population health. You know, so we look at total cost, we look at condition prevalence, we look at quality measures, and we look at also utilization. You're able to look at it by region within the state and see where we have improvements and where we have opportunities to make change as well. And we also have our new pricing model that just rolled out in July. So we look at price comparison. We just rolled out and started out with imaging services. We're now going to be adding in x-rays, and then we're actually bringing in episode-based analytics for the top inpatient and outpatient procedures as well. so we can start looking at comparisons, and those will all be on our site. So I welcome you to look at it. We also report spot analyses that take very critical, what are the top of mind topics. One was emergency use. We had one of our analysts that said, you know, the day that we have less from NBC News talk about civic analytics is the day that I'm going to go do something different. Well, anyway, less used our analytics on emergency use, in which if we just changed the mode of where services are performed alone on emergency use, that can be performed within, you know, again, inpatient or professional-based services, we could save over $800 million in just that one specific category of care. So again, they used it. It is part of legislation that is being written. They utilized our analytics, and I guess that's the key, whether it's statewide policy, whether it's national-based policy, is how do we go ahead and continue to use and develop analytics that help drive change.
Anna, thank you so much. Well, we do want to save time for some questions at the end, and we will get to those questions. But before we open it up to the audience, we did want to hear from our national experts. So I'll let them introduce themselves, but we have Denise Love from the National Association of Health Data Organizations, all the way down there on my right, your left. And down here we have Joe Porter from the University of New Hampshire, also the co-chair of the APCD Council.
My job is to be brief and kick off this discussion. And using Craig's terminology, I think Joe Porter and I can consider ourselves APCD midwives. Because I think we've been at pretty much, I don't want to say conception, but, you know, before they were data, gleams in the legislators' eyes, which makes it really interesting because as we go across the country over the last decade, I'll mention that briefly, it's really not a partisan issue. I mean, the red states need and want these data. The blue states need and want these data, but maybe the use cases and the stories and the justifications are tweaked a little bit because Massachusetts might want it more for reform-oriented, where Arkansas might want more consumer pricing information. So I want to just lay the groundwork about who we are. We're this national expert thing. And so I'll say briefly that I'm from the National Association of Health Data Organizations that has been kind of linked at the hip with OSHPD since the 80s. And NATO has worked with states to implement and expand their hospital reporting facility-based systems over 3 decades. And the power of state-to-state sharing and uniformity is just so proven. But hospital data wasn't getting the states that far in the new world of healthcare transformation, payment reform. Everybody needed some outpatient data. They needed physician data. They wanted payment data. So this little thing started in the Northeast called the Regional All-Payer Health Information Council. And we had a joint meeting with the University of New Hampshire and NATO in Beverly, Massachusetts, that wonderful day where 25 states came. We talked APCD. Those little 5 states in the Northeast started this thing with all-payer claims and shared learning. But then we were getting calls, well, I'm from Oregon, or I'm from Utah, we're NATO members, we're from Florida, we're not part of that Northeast. So we joined forces. So NATO and UNH have really joined together in a joint collaboration called the All-Payer Claims Database Council and Learning Network. We really provide front-end technical assistance to states, and we have done this for a decade, and we'll talk about some of our lessons learned that can inform California. We do a lot of shared learning. I guarantee that things that will come up as you move forward, have come up somewhere, and maybe with a unique spin. But there is quite a bit to draw on from states that are up here on this stage and others. And then really catalyzing the states together, we work on common goals, whether it's writing to Congress or writing to SAMHSA on 42 CFR Part 2 or labor. Those states working together have a louder voice than each state just trying to figure it out on their own. So I will say this, that we will go over this briefly. I'll turn it over to Joe, but states differ. I mean, that's clear. There's variation in governance and political structures, but what I'm always struck with is how remarkably common the data issues are. I mean, it's the same data elements, often the same submitters, national payers, and so those types of things we can work together on. And I do think that states up here and what California is doing and other states that are working on this are really investing in the future. It isn't what data can come out in the next year as much as what is going to be your touchstone for the next 5 years as things just really rapidly evolve and change. So this investment is important going forward. So I will turn it over. This is an evidence-based framework. This really reflects the lessons learned over the last decade, and Joe will talk about each component here that must be put in place for a sustained and successful implementation.
I have this, I need that. The slide. Thank you. All right, no. And just to keep with the theme, I will just let everybody know that in Beverly, Massachusetts, I was 8 months pregnant. So my son is now 10, so that tells you how long we've been doing this. So as Denise said, I think we were asked by another foundation several years ago to come up with this manual for the development of APCDs that could summarize some of the process that states go through and some of the lessons learned to give guidance to states as they go down the APCD path, and that's where this comes from. As Denise said, I'll mention each of the areas briefly, and then I know we have time for questions, so I'm realizing that we have about 4 minutes to go from putting a ring on it to a toddler. So that's good. So the first phase, as we describe it, is engagement. So that's what we're doing today. I mean, this is about engagement. This is what is the vision for this system? What are the use cases that are of most interest to this state and the stakeholders that are going to be engaged in this process going forward? Who are those stakeholders and how do they want to provide input into the system, not just at its inception, but throughout the course of development and refinement of the APCD? As Denise mentioned, every state is a little different. Some of those differences stem from differences in state law. So what are those legal considerations for California? How do those compare to other states, and what sort of solutions can be met for some of those legal issues, drawing either from a previous experience in California or experiences in other states? Governance is another big issue. I'm realizing a slide I think is missing for governance. That's our fault. Sorry about that. But the governance components really are, can you leverage existing infrastructure, other state agency work that's been done in the past to establish data systems, to protect them, to address privacy issues? How can you use advisory committees? Where will you put the centralized location for ownership of these systems, and who's ultimately responsible for those? And there's a continual convening and management function with all APCDs, and that all sits into this governance structure. Everybody asks, rightfully, what is the funding model of this? And each of the 3 states here can talk a little bit about some of the differences in how those are met, and the other 14 states could talk to you about their differences as well. But suffice it to say, in general, one of the things that is a lesson learned around this is to diversify that funding, that there are many streams of funding that a state should consider, and also different users that have needs that potentially could help offset some of the costs for the system. So diversification is really important. The first question here is, what are the sources, that's plural for a reason, of implementation funding and continual funding down the road as well. Oops, too fast. Technical build, I love that this is one slide. right? Because this is like a really big deal. So, you know, there are a lot of technical questions around these databases. They're not for the faint of heart. We were talking earlier about when you have an APCD at the state level, you'll often have a user who comes in and says, hey, I want that data, like it's one thing. It's one Excel spreadsheet that they're going to get. The technical build can be fairly complicated, dependent on the number of lives. Obviously, California is a significant undertaking, but not one that isn't without precedence in some of the work that's been done. There will be reporting needs of the system. We've talked extensively in our community of APCDs about quality assurance checking. That in and of itself could be an hour and a half. Most of you probably wouldn't want to stay for that, but it certainly could be. And so there's a lot of sub-questions under the technical build, but it really is the foundation and the infrastructure of your data system that then feeds how you share data, how you analyze data, how you check the data. So the technical build is typically a very significant undertaking, one that most states have some sort of vendor contract for. So there's a community of vendors who have been developing their systems over the past 10 years as well. And so there is a lot of history, again, in that. I think, you know, what we've seen is a tremendous amount of learning around the nuances around APCD data, and there have been some really good solutions that have been put into place, and that is a continual learning process for sure. States on that technical build, just one other note, is usually a partnership with your vendor. The states don't hand this responsibility over and say, you know, great, check that box. There's a continual process of learning with the vendors and a very active role at the state level with that vendor contract. Analysis and application development, similarly, there's an analytic plan that typically gets developed in the beginning of an all-payer claims database process that starts to define what are the use cases, who are our audiences, what access points would each of them want, and in what way, and how can we satisfy the needs of the users, and also ensure that we have set realistic expectations in an analytic plan. So similarly to having some users come in and say, hey, I want the data, expecting, you know, one file. You also have some folks who say, I want to use the data to do X, Y, and Z that are just not feasible with the data as they are. And so there's a lot of work in the early phases of an APCD to define what the data are, to understand the data elements, and to feed the audience and the community of potential users with some information about what it could potentially be used for and how it can answer certain questions, but it is not everything to everybody, but it probably has a little bit of something for most folks. Again, you know, most states, similar to the technical build, don't hand off the analytic responsibility to some vendor and say, okay, you know, we're good here, or they're just going to do that work for us. There is a real partnership at the analytic vendor community where some folks at the state level are doing some analytic work. There's some things that may get contracted out as far as regular reporting cycles, but it's a continual learning process, and I would suggest, and the state colleagues can talk about this a little bit more, that we are answering questions with APCDs now that we never had when we developed them 10 years ago. And that's where this continual process happens around what do we want this analytic plan to look like. And it, like most other things, is not a static document that changes over time. And the responsiveness, I think all three states have talked a little bit about this, of the data system on a topic. I know Craig talked about the EpiPen. Colorado did a thing around the EpiPen too, just what are these costs? And we hear it's a big issue, but what data do we have to support some of the concerns that we have around that? And so there's been a lot of work done both at the vendor community and the state community to have a combination of functions that allow for the really important questions to get asked and answered in these analytic plans. So finally, I will close with a few broad lessons, and then obviously there's time for questions and answers too. Multi-stakeholder approach. Again, there is this greatness on the APCD that it has a little bit for most people, which means that most people want to be involved. And the payer community that's submitting data and ultimately potentially using data, the provider community who are being reflected in the data, the analytic community, the researchers, the policymakers, the multi-stakeholder approach is incredibly important. And you will be back and forth talking to most of these stakeholders continually through the process. So having that relationship building is really important. Also important are the transparency and the documentation. So, in general, the data submission guides are public. There's a public comment period on them. They're not black box. They are, here's what we're expecting you to do. Here's the thresholds that you have. If you don't hit this threshold, that's why you get rejected. It is not ever meant to be, give us our data and we're not going to tell you what happens from here. Understanding the use and limitations of the data. Again, it's great to answer a lot of questions, but there are limitations. It can't do everything, and it's not perfect. Anna was saying earlier that perfect is an unallowable word because, that you just can't get to 100% accuracy in all things all the time. Seizing integration and linkage opportunities. Deb talked about a really important project that Massachusetts has done to look at these data in the context of the other information that we have as a state. That's a really important component of an APCD. Scott talked a little bit about the vision for some of that linkage. That becomes incredibly important to think about what we're learning from the APCD, not in and of itself, but in the greater context of other things that we know about as well. And we'll just keep going back to use cases. There's a reason we started with the use cases. It's because it is why folks want to do this work. And it's not a small undertaking, but we know that if we define what we care about, we can leverage the data in order to help us meet some of those needs that we might not be able to meet otherwise. So with that, there's some contact information for our team. Denise and I are here, but there is a small but mighty team associated with us. And our contact information is there should anybody want to connect with us after this session is over.
Thank you so much. I want to thank the panel again, not only for providing excellent information, but miraculously, we are right on time. So we have about 15 or 20 minutes to take questions from the audience.
How have you as states dealt with the challenge, which I think may be bigger here in California, of collecting meaningful claims data from capitated systems? I'm very interested in that.
So Anna, I know you have HMOs in Colorado. Do you want to start?
Yeah, so can you hear me? Yeah. Okay, so several ways. So one is Kaiser is within our environment. So they're a staff model. Around 30% of their business is flowing through fee-for-service because they have a network as well. But within the Denver metro area, it's predominantly their staff model. So they have been providing us fee-for-service equivalents. As well as all of the encounter data and information. That has taken a lot of work in conjunction with Kaiser to get to that point. And then, periodically over time, which is why the QC is so important, other hurdles come up as well. In addition, as we know, there are alternate payment models that are out there. Colorado just put into its regulatory environment the addition of APMs, which includes global cap, incentive payments, quality payments, various number of different categories. We also are bringing in pharmacy rebate information as well. Massachusetts already had done that. So those are supplemental submissions, not included with the monthly data feeds, but those are very, very critical to understanding as to what's actually happening across the board within healthcare.
Likewise, Massachusetts, we flag the claims coming in as capitated, and a lot of times they are missing the paid amount, but it's good for utilization, and our plan is to work with the payers to get a fee-for-service equivalent if it's missing, or to create a fee-for-service equivalent kind of charge master, kind of a big, or actually payment fee schedule and plug that in. So there's a couple of different methodology. I think the important part is looking at the payers and products where you're doing DQ and then seeing, before you do an analysis to make sure you're not underreporting something. And they can actually, through Tableau, you can see something either be too low or too high. And you say, okay, this one's like 10% of what everyone else is. Why did they get such reduced payment? And you can actually see that you look into their data and they've dropped the fee for service equivalent. So those are some of the things we've learned.
Thanks. Karen, you want to grab Lance? 1 sec, Lance. Wait for the mic.
Figure out the microphone. Lance Lang from Covered California. I think it's useful to try to back engineer capitated systems to fee for service, but the mandate under the Affordable Care Act is to go the other direction. And there's insights in care delivery from truly integrated capitated systems that aren't recognized when you back engineer. So what advice do any of you have for us to think ahead to the nirvana where we really do move away from fee for service?
My suggestion is working with the payers ahead of time. So as things are evolving, making sure you're meeting with them, understanding what their plans are, and actually work with them. They're the best people to say, yeah, we're changing our adjudication systems or our data warehouses. Yeah, we can give you this. They need that information as well. So it's nothing that is a surprise to them. So definitely leverage what they have and work that in. Don't work in a silo, I think is the most important part that I would.
Simply adapt, adjust, evolve. I think the name of that you're not naming it an all-payer claims database is step one. And so it's really about evolving, and there's value to be gained by ensuring that you're producing the right type of analysis and information based on the current and evolving environment.
Thanks. Crystal?
Please forgive my question. I'm a technologist, so this is kind of state-specific, but given the percentage of the population that is reported on in your specific systems, how many claim encounters do you receive on a monthly basis? And I understand you might not have the answer, and I can follow up later.
Yeah, for me, you're asking the wrong person on that. Our data guru, Kinley Money, who's fantastic, would be able to answer that just like that. I would say more broadly, though, we receive quarterly information compared to the others here from submitting entities that have 2,000 or more covered lives. So we receive information, and for a small state like Arkansas, about 3 million in the population, we also get about 80 to 85% of the covered lives, and that comes from about 55 to 60 different submitting entities. I can't tell you the number of records that we receive on it is a lot, though.
More than 20, but I'll be happy to, if you want to leave your information, I could send, we have a chart on that, I'd be happy to send that to you. So as a follow-up, absolutely.
We've got close to around 900 million claims that's in our database, and each claim is made up of a multitude of claim line level details, whether they're encounters or they're on the fee-for-service side. So it's a multiplier effect. We have 75 submitters that are submitting to us every single month, including both. But again, we can always follow up with the very specific details.
Karen?
Hi, thank you all for your presentation. My name is Adam Francis. I work for the California Academy of Family Physicians, and our members have had a lot of challenges in dealing with claims data and the accuracy of claims data, and I know we can't make the perfect the enemy of the good, but I was wondering if any of your states or organizations have done anything to really tackle data integrity, and if there's any particular tool you've used to create more accuracy or particular hurdle that you've come across.
I think one of the earlier on with our APCD, Massachusetts decided to do the ACA risk adjustment program. We're the only state in the country to do that. We did it for a couple of years. So when it involved payments to the payers, the data got very complete pretty quickly and more accurate and more. So that was one lesson learned. On the other side, I would say anything that we produced, even on our consumer website, we sent the data files out to all the payers, payers and providers. So providers could actually review their data and say, yeah, this is about right, or, I get paid $45 for that, and you said 47. So, and we would explain the methodology with them, and we had a lot of stakeholder engagement with the Mass Medical Society and all the kind of the committees underneath that and all the hospital groups. So that was very useful. And then people felt fairly comfortable with it. And then they could also report back any really big differences. We also adjusted the data when that happened.
I have to say the overall stakeholders having confidence in the data is so critical because then they'll use the data. So right now that is significantly growing. The use and the confidence and the perceptions associated with the APCD is extremely high. Again, not perfect, but it is extremely valid. We go through a process that as we get in submissions, we have a significant number of tools that provide key indicators that go straight back regarding counts, PMPMs, et cetera, that go back to the submitters, and they validate that the numbers are in line with what they had submitted to us. And likewise, as we do any of our reporting, we give the stakeholders the opportunity of those that are impacted, such as the hospitals or physician groups, they have the opportunity to preview the data and validate it against their own, and there's a lot of discussions that go on. Some of it may be methodology, some of it may be that they're also looking at out-of-state services that are occurring within their facilities that they need to back out as well. But we go through and take a lot of pride, and this takes a lot of work, not only on the data validation side, but just in the communication and the time that it takes to ensure that they're having the opportunity to review in advance.
I'll echo that. The time that it takes for data validation and quality checks is enormous, even on a quarterly basis for us. We've got a lot of that automated, and the provision of reports back to the submitting entities to ensure that the data that we're collecting and we're doing quality checks on is valid and available. I would also say that we kind of hold two hats, so we're a user of the data as well from our policy side. So having our analysts get in and look at the data and try to answer questions on our own helps us understand what the data is and what the gaps are and what the information means. So I think that's been helpful for us. I think we also carry a mantra with our stakeholders, particularly when it relates to consumer transparency or any information that's going to be used to make reimbursement determinations or policy changes, and that is no surprises. You got to have that mantra of no surprises so that people can provide you with feedback on the information before decisions are made.
Thank you.
Pamela Rosada, California Research Bureau. I don't know if this is working. I'm really excited to hear about this. As a public policy researcher, anything that will give me more data makes me very happy. Very excited to hear Arkansas about that cannabis connection. It'll be really interesting to see how that plays out in the long term. Massachusetts, love that you're looking at cost comparisons. Curious though, I've seen a lot of studies coming across my desk in the last year and a half, 2 years, that talk about quality of care. I've heard the word quality assurance used once. I was a little bit late. It was used in reference to the data itself. But to what extent are you looking at the cost of care as compared to the quality? The studies I'm seeing say that a gallbladder surgery that costs 10 times as much isn't necessarily a better surgery, and in fact, it's often worse. Are you looking at that?
Great question. So on our consumer website, there's the individual provider costs, which include both, it's outpatient, 300 procedures or so right now. We're going to be moving more into episode-based. But right now you look up the cost, and then there's a little button you can push to get the quality measures. But the issue is that there aren't a whole lot of quality measures for the physicians. So it usually goes if there's the hospital, if they're associated with the hospital. So we'll have leapfrog and that type of thing. So we definitely, it has to be both. So that's our mission. And it's, again, a beta website. So that's how we're tackling.
As a part of our population health reporting, there are quality indicators that are reported as well. Also, by statute, no physician price or physician practice price cannot be reported without an associated quality measure. We carry that over to all price reporting that we do. We also look at Leapfrog. We look at the CMS 5-star ratings, especially on the facility side. Some of the facilities, such as outpatient services, it's really difficult. There is not a national place for us to get those. So we work to try to put together claim-based clinical measures. Again, that's oxymoron right there, but it is, again, we try to find very creative ways and go through different advisory groups to help find what is, and evaluation committees to really say, okay, what's the most appropriate one?
And as a consumer myself, I do think that a proxy measure that I have trouble getting a hold of is volume. We know that volume for some things is linked to quality. We can't really get at sometimes that patient experience that's linked to that service, but we can, I think, through these and other databases, do a better job of reporting volume.
Did you want to jump?
Yeah, I mean, as a director of health policy, you always have to consider quality along with cost as well as access, right? Looking at all those things and the trade-offs, particularly when you begin speaking with legislators, is critically important. So you can't look at it in isolation. I would say more generally, one of the very gratifying things that I've begun to see out of the Arkansas all-payer claims database is the level of interest from researchers, and just making the data available, not just for, you get certain currencies from legislators and funders about consumer transparency, which is important, but making this robust, comprehensive data available to researchers to generate new knowledge is key, and we've seen a lot of interest both locally and nationally in the data in Arkansas. So that's been promising moving forward.
Great.
Is it possible to track the data by individual patients so you could follow follow-up exams? Because I'm an RN. Additional follow-up exams are going to mean there's more complications. Is it possible to do that as a quality assurance?
Yes.
We have, I think most of us have a master patient index, so it's linked so you can follow a patient from Mass Health through commercial payers.
Yeah, and
I'm going to say HIPAA. Okay, so we manage very closely to that, but in the case of healthcare operations, we have a lot that we can do in providing that detailed information back to the providers. And the one key is that providers only see, for the most part, the services that they perform. And then from the payers, what we hear is they get this one overall number, that summarizes the other care that their patients have received. In this case, we're doing a lot on healthcare operations and providing them a full picture of all of the care associated with their attributed patients, and down to the individual. But again, all falling under HIPAA and under the provisions under healthcare operations.
And I want to clarify, in Massachusetts, all our identifiers are hashed, so we never see it. So it's we can link because we use a similar hashing algorithm to other databases, but we can never ever see name. We don't even get it. So.
That's what we have in Arkansas, is a hashed ID that allows us to link across the different data sets. And that, in fact, includes the medical marijuana qualifying patient data set, as well as vital records from the Department of Health, which are mandated to be a part of the all-payer claims database. Critically, I want to say, just as we're moving forward, both in terms of alternate payment methodologies, but more broadly in terms of social determinants of health, the ability to link across these different data sets, whether it be education or criminal justice, whatever it is, bringing those liberated data sources together to better understand not just how the healthcare system is performing, but what is impacting healthcare system utilization and costs and access. That's going to be critical, and I think we need to have a vision toward that, both in Arkansas as well as our other states, and I know you guys beginning the process here, that's going to be critical.
Thank you. We have time for just one or two more questions. Karen?
Hi there. Sammy Chang for the UC18 source on healthcare price and competition. The question I had was, how has the U.S. Supreme Court case Go Bay affected your state's functioning of the APCD? And did that leave a big hole of data that you all needed, and how do you all get around that loophole or use legal mechanism to get the data you need?
Joe, do you want to? Yeah.
Okay, yeah, that is.
We do have a minute or two on this.
Discussion. I mean, well, I know the three of us in particular participated quite a bit in that activity, shall we say. But, so what basically falls under the state jurisdiction is all of the fully insured as well as the non-ERISA. Our estimates, Colorado does not have legislative the ASOs, the Administrative Service Organizations or third-party administrators. So we really don't have a good count of exactly who is self-insured or not. But we've got around 50% of the self-insured within our environment, or within our database. As to how we're handling the ERISA-based that falls under the Supreme Court ruling under Gobey, is we now have the employers angry as hell. And they are now starting to get engaged. We have the Colorado Business Group on Health is extremely active, and we now have engaged the Denver Metro Chamber, which basically speaks from a statewide perspective as well. So they have pulled together a healthcare coalition. They have brought in all of their employers. They have brought in a coalition that is made up of pharma, payer, physician groups, or hospital facilities, as well as employers, and then they have a separate group that they basically pulled together for on the consumer side. A full set of recommendations has been put in place, and they now have developed their implementation plan. And a part of it is starting with the larger employers, that they on their own voluntarily submit to the Colorado APCD. So they have their board meeting. Our challenge that we have in conjunction with the payers is coming up with a simplified approach, which is not really existent, but it does, require some documentation. But we have engagement from the employer side, and they are, in conjunction with the consumers, the driver of really how change is going to happen. At least that's the stance that we're taking in Colorado, and we're getting a lot of momentum there.
We're doing a similar thing where we're going to, one of the plans is collecting data from their self-insured or trying to press them to give it to us. And then as an agency, we're going to go out to the larger employers and say, why don't you come on board? And we figure the more usable and the more benchmarks are out there, they're going to say, we want to be a part of this too. So it's going to be probably a couple-year process to get people on board, but we're hoping if we do a good enough job that people will come back.
And I think that's the theme across all of the states, is that that engagement at the employer level and the identification of use cases of the data and reporting are the things that the employer community has asked for, sort of system-wide data across payers, regional approaches, or regional looks at their populations. Those sorts of things are where the states have generated the most interest at the employer level, and the employers then have the ability to say, I want my data as part of that as well. So that's where we've seen a lot of activity since the Gobey ruling.
Thank you. Time for one last question.
I'll try to be
Please, go
quick,
ahead.
but it's a good connection to what you were just talking about, in that if you could go back to the beginning, I suppose, and you think about sort of the future of what this looks like, particularly in the New England area where there's a lot of regional, opportunities to share. What would you do, or what do you think about? What does the future of this look like, so that, those lessons are shared early on?
Joe or Denise, do you want to take that one in 1 minute?
Yeah. So, I think the future is what healthcare dollars are being spent outside of the claims transaction, and how do we solve for that? I think that's a big piece. That's actually obviously that's not as historical, maybe. I think the lesson from history that we continue to do, which we talked a little bit about already, is that partnership on the payer side to understand how their systems are changing and what data they're collecting that can be submitted back is one of the most important parts of the conversation. I think when there were just a couple of states, there was this really interactive conversation about this data element doesn't mean this, and this data element doesn't mean that, and this data element doesn't mean this. I think we regrounded ourselves in that about a year and a half ago after the Go Bay decision, when we started to work on this, what we call a common data layout. So I think staying very grounded in an understanding of what data the carriers are collecting that you're going to get back and what that means to them, so that you also know what it could potentially mean to you, is that iterative history that we continue to build on and becomes probably some of the most valuable information from the system standpoint.
Thank you. Well, I have 3 final requests for you. The first one is, you will see, I think in your packet, there's an evaluation form. It's bright yellow or orange. If you could take a look at that, fill it out. It shouldn't take you more than 10 or 15 seconds. We really do rely on these things at the foundation to inform our programming and lets us know topics that you're interested in. Please do that. The second thing is, if you are interested in the drug Medi-Cal briefing that is taking place on December 6th, please go to our website, chcf.org, and take a look for the information and get registered. And the last thing is, please join me in thanking this wonderful panel which has come in from around the country to talk about data today. Thank you all so much.